Today's topic is mastoidectomy and meatoplasty. I am Dr. Parvez Ahmed Rishi. I am not associated with any institution and I don't represent any department or any institution. I don't pay or accept money from anybody. I do it for free. In the history of mastoidectomy, 1873, Shorts described cortical mastoidectomy. In 1890, Zofall introduced radical mastoidectomy. In 1902, Sir Charles Balancy described ligating the jugular vein and draining the lateral sinus as well as grafting the mastoid cavity to facilitate better healing. In 1910, Bondi described opening the epitympanum and leaving the middle ear intact. Lamport popularized the use of drill and loop magnificence. Janssen introduced intact canal wall mastoidectomy with fascial recess approach. Anatomical considerations. Now let us see that the mastoid, the temporal bone, consists of four parts. This is the squamous part. This part is the flat part is the squamous part. Then we have the tympanic part. This part is the tympanic part. You can see tympanic part. This is the mastoid part. This part is the mastoid part. And at the behind is the petrous part is at the behind. The suprameatal supine, which is this, the suprameatal supine. It is the suprameatal supine. It is a small bony protuberance that extends superficially from posterior and superior bony external artery canal. Posterior to the suprameatal supine is a group of small holes. Posterior to this is this group of small holes is seen described as cribriform area. It approximates the location of underlying mastoid antrum. So there is location of, so this is sulcus of this, okay, and then we have the cribriform area lies, this is the cribriform area, this cribriform area lies within the Massman's triangle, the imaginary triangle defined by three lines. This is one line, this is second line, and the third line is like this, perpendicular tangent, okay. Temporal line, so this is the temporal line. This is the line formed by the superior and posterior margins of external artery canal, superior and posterior margins of artery canal, line ran perpendicular to first line and tangent to the second line. So this is perpendicular to first line and tangent to the second line like this, okay. Mastoid antrum lies around 1.25 cm, 1.5 cm deep from the surface of Massman's triangle. Symba concha, it is the soft tissue anatomical landmark for the mastoid cavity. Fascial bridge, this is the fascial bridge. You can see fascial bridge is a part of portion of posterior superior bony meatal wall. Bony ridge is meatal wall. It is the bony meatal wall that bridges over the notch of ravinus and overlies the ossicles. You can simply remember fascial bridge is bony wall, bony meatal wall that overlies the ossicles. Fascial ridge. Fascial ridge is the part of bony meatal wall which houses the posterior bend and vertical segment of the fascial nerve. Here lies the vertical segment of the fascial nerve. This is fascial ridge. Now we have the anterior buttress is the point at which the posterior bony canal wall meets the tegmen. The posterior bony canal wall reaches the tegmen, meets the tegmen is called anterior buttress. Posterior buttress makes the meeting of the posterior canal wall and the floor of EAC lateral to the fascial nerve. Floor of the EAC lateral to the fascial nerve. Okay. Now you can see this is the mastoid cavity. This is posterior buttress, fascial ridge, anterior buttress, eustachian tube, fascial ridge. This diagram is very important. Many slides we will discuss by using this diagram. So we will skip these things, we will skip it. This is the Sytely's angle. Sinodural angle is an angle between the sigmoid sinus and the middle fossa dural palate. Solid angle is the area where three bony semicircular circular canals meet. This is the solid angle. At the solid angle, the three semicircular canals meet. When the dura meets the sigmoid sinus, it is called a sinodural angle. Sinodural angle or Sytely's angle. Now the Trotman triangle, those are angles. Now we have a triangle also. That triangle is bounded anteriorly by the solid angle, posteriorly by the sinus, palate by the sinus, and superiorly by the tegmen. Is bounded by bony labyrinth solid angle anteriorly, sigmoid sinus posteriorly, and dura superiorly. Now we have Donaldson's line is a line passing through the horizontal semicircular canal. So the line, there is a line that passes through horizontal semicircular canal and bisects the posterior semicircular canal. What is that line? That is Donaldson's line. What is importance of Donaldson's line? It is a landmark for endolymphatic sac. Line is landmark for endolymphatic sac. Now this is sinodural, this is the dura, this is the sinus. This is sinodural angle, okay. Now this is our Sytely's triangle or Sytely's angle. Now this is Trotman's angle. So Trotman's triangle. Now this is Donaldson's line. This is endolymphatic sac. This is the fascial nerve. This is EAC. Now Donaldson's line passes through the horizontal semicircular canal, divides the posterior semicircular canal. What is the aim of mastoid surgery? Eradication of disease, make the ear safe, preservation of hearing if possible. So three functions of mastoid surgery: remove the disease, make ear safe, reconstitute the hearing. Conservative management indications: the attic defect is large, with the cholesteatoma sac is shallow, old patient unfit for surgery. These are indications. So we have these are we can do conservative management in these. Conservative management, indications of conservative management. Also, we don't do surgery. It is attic defect, old patient unfit for surgery. Now we have contraindications of conservative management. Radiological evidence of an enlarged smooth-walled antrum indicating a large cholesteatoma cavity. Otorrhea persists after several cleanings. A very small attic perforation makes cleaning painful, difficult and unsatisfactory. Cholesteatoma is observed behind the pars tensa. There are symptoms or signs of erosion of vital structures such as the fallopian canal, semicircular canals, cochlea or dura. There is hearing loss, either conductive or sensorineural, indicating progression of cholesteatoma. The patient is uncooperative or is geographically unable for necessary management. So these are contraindications to conservative management. Anyway, these are indications for surgery. Now what we do the surgical management, we go for mastoid procedures. Simple mastoidectomy, canal wall up mastoidectomy, canal wall down mastoidectomy, radical mastoidectomy or modified radical mastoidectomy and mastoid obliteration. Canal wall up, simple cortical complete shortest mastoidectomy, classical intact canal wall mastoidectomy, combined approach tympanoplasty, atticotomy, atticoenterotomy, radical mastoidectomy and modified radical mastoidectomy Bondi's procedure and retrograde mastoidectomy. So when we lower down the canal wall, it is called a canal wall down. Atticotomy, atticoenterotomy, radical mastoidectomy, modified radical mastoidectomy procedure, retrograde mastoidectomy, simple cortical complete shortest mastoidectomy, classical intact canal wall mastoidectomy, combined approach tympanoplasty. So these are canal wall up procedures. Now classification in relation to the removal of the bony ear canal and obliteration of ear cavity. Now we have the canal wall. Now you have removed the EAC ear canal wall. Canal wall down mastoidectomy, we call it the canal wall down mastoidectomy. Now we also call as atticoenterotomy. If we obliterate the cavity, if we do not obliterate the cavity, this is called open cavity, or the procedure is called a bondage operation. Now it is called the open technique of mastoidectomy. Now if you obliterate the cavity partially or total, and this is called a closed technique mastoidectomy. Okay. If ear wall you keep it intact or partially intact, canal wall up mastoidectomy. It is classical and modified. Now repneumatization may occur. So, but it is known as closed technique because we close the cavity, we are keeping the canal wall intact and there is no cavity. What are the approaches to the middle ear? Method of access to the middle ear through the soft tissue. We go through the soft tissue, and what are the approaches? We go endoral, post-oral, extended endoral, and circumferential. So four approaches. What are the routes to the middle ear? The method of access to the middle ear through the bone. These are the methods, transcortical method and transmeatal method. We go through the bone, transcortical. We go through the meatus is transmeatal. Transmeatal is microscopic and endoscopic. And oral approach indications head-on access to the mesotympanum, epitympanum, and editus and antrum. So if we open the endoral approach, we are directly reaching the editus, epitympanum, editus, antrum, and mesotympanum. It is head-on access. But disadvantage is stenosis of EAC. EAC may get stenosed. Difficult access to the mastoid tip. Tip cannot be cleared. Post-oral approach, we can see a Wildes incision here. Good exposure to entire mastoid bowel and epitympanum. Circumferential approach, you can give a circumferential approach, you can do end oral and then proceed to the post oral, and this is circumferential approach. Technique: anterior to posterior, in to out, posterior to anterior, out to in. Size of cavity is small. Good approach for sclerotic mastoid. Safe early identification of ossicles. Less chance of missing small mastoid. Technically difficult. Posterior to anterior easier, preferred in complicated cases. Cavity is large, chance of missing antrum. Simple mastoidectomy involves removing the mastoid cortex and varying amounts of the air cell system depending on the disease process. It is usually used when mastoidectomy is done for drainage of mastoid abscess. Cortical mastoidectomy. Cortical mastoidectomy is a transcortical opening of the mastoid cells and the antrum. It is initial stage of any transmastoid surgery of middle ear, inner ear, facial nerve, endolymphatic sac, labyrinth, IAC, and sickle base. Now we can see this is the dural palate, middle fossa tegmen or middle fossa tegmen. This is the sinus. This is sinodural angle here, Stiles angle. And this is the mastoid antrum, mastoid cavity. This is EAC wall. It is thinned out, intact wall. Okay. This is digastric ridge here. And indications of cortical mastoidectomy. coalescent mastoiditis and masked mastoiditis. COM safe, active, refractory to antibiotics. Secondary otitis media refractive to antibiotics. Endolymphatic sac surgery, facial nerve decompression, vestibulocochlear nerve section, translabyrinthine approach for CP angle, cochlear implant surgery, combined approach tympanoplasty. Combined approach tympanoplasty CAT, also called as classical intact canal wall mastoidectomy. So here the canal wall is intact. CAT consists of large mastoidectomy with an intact but thin bony ear canal wall and posterior aticotympanotomy. The intact canal wall technique is performed in two stages. The first operation is performed to remove all cholesteatoma and repair the tympanic membrane. 6 months later, second operation is performed to inspect the mastoid and middle ear residual or recurrent cholesteatoma and to improve hearing by oscular reconstruction. Steps of cortical mastoidectomy. Cortical mastoidectomy is the first steps of CAT. Anterior tympanotomy and tympanomeatal flap. Posterior tympanotomy via fascial recess approach. Tympanoplasty. We will show these both via fascial recess. Have a look at cortical mastoidectomy. This is the dural or tegmen palate. This is sinus palate. This is digastric ridge. This is posterior canal wall. This is the lateral semicircular canal, and this is the eustachian tube. This is external. This is the tympanic membrane. Okay, area. Now we have anterior tympanotomy. Through anterior tympanotomy, we have cut this and we have gone anteriorly. Anterior tympanotomy, we have approached through. We have gone through the we have done the mastoidectomy, cortical mastoidectomy. Here you can say posterior tympanotomy. Through posterior tympanotomy, we have opened the fascial recess. This is the fascial recess, this is the incus short process. This is the chorda tympani, this is the digastric ridge, this is fascial nerve mastoid segment. We have gone through the fascial recess. This is called posterior tympanotomy through fascial recess approach. This is a step in cortical mastoidectomy. Aticotomy, also called as epitympanotomy, denotes opening of the attic, performed through the transmeatal route. Aticoenterotomy is an extension of the aticotomy in a posterior direction through the transmeatal route, in which lateral attic and ectus walls are removed and antrum is entered. It can be performed through the transcortical route but is usually performed through the transmeatal route. Bondi's operation and aticoenterotomy is called Bondi's operation if the tympanic cavity is not entered. Useful for attic and mastoid cholesteatoma. No involvement of middle ear space. Cholesteatoma lateral to ossicles. You can see this is aticoenterostomy. We have cut the attic and the antrum. Aticoenterostomy. Okay. Fascial ridges as such eustachian tube, we didn't do anything anywhere. Now here you can see this is lateral process of malleus. This is the superior section. This is the anterior direction, superior direction. We can see fascial nerve. We can see short process of incus here. Fascial nerve, oval window, stapedius tendon. You can see chorda tympani nerve, promontory, manubrium of malleus. We have see tympanomeatal flap. Okay. Bondi's operation. This is the Bondi's operation we are doing. Bondi's operation is Radical mastoidectomy. Radical mastoidectomy is a canal wall down mastoidectomy performed to eradicate disease from middle ear cleft, in which mastoid cavity, tympanum, and EAC are converted into a common cavity exteriorized through the EAC. Where in the structures of the tympanic cavity, remnants of incus malleus and remnants are removed and eustachian tube is occluded. We exteriorize the whole ear, we remove everything. That is radical mastoidectomy. Radical mastoidectomy, you can see the boundaries are there, eustachian tube has been blocked and we have removed whole of ear. This is one simple cavity exteriorized through the EAC. Indications of radical unresectable cholesteatoma extending down the eustachian tube or into the petrous apex. Premonitory cochlear fistula caused by cholesteatoma. Chronic perilabyrinthine osteitis and cholesteatoma that cannot be removed and must be cleaned or inspected periodically. Resection of temporal bone neoplasm with periodic monitoring. Modified radical mastoidectomy. Modified radical mastoidectomy refers to the Bondi's procedure in which disease limited to the epitympanum is simply exteriorized by removing the portion of adjacent superior or posterior canal wall. The term modified radical mastoidectomy is used interchangeably with canal wall down mastoidectomy. Modified radical mastoidectomy, dural or Tegman palate. This is sinus palate, this is facial ridge forward, this is digastric tendon, lateral semicircular canal. So we have done modified radical mastoidectomy or modified Bondi's procedure. Indications of MRM, absolute indications, unresectable disease, unreconstructable posterior canal wall, failure of first stage canal wall up procedure because of poor ET function, inadequate patient follow-up. Disease in only hearing, ear or in the dead ear, medical illness, severe, these are relative indicators, severe otological or CNS complications, neoplasm, poor ET function. Contraindications of MRM, COM without cholesteatoma, persistent secretory otitis media, chronic allergic otitis media, tuberculous otitis media. Canal wall up versus canal wall down. The choice of preserving or removing the posterior wall of the EAC, that is canal wall up versus canal wall down mastoidectomy, has been extensively debated. The preservation of the canal wall is preferred. The decision to remove the wall is most often made during surgery, when the extent of the disease is fully appreciated. Intraoperative findings that may be indication for canal wall down procedure include labyrinthine fistula, unresectable disease or fascial nerve or stapes foot palate, low-lying tegmen that limits access to the attic, unresectable sinus tympanic disease, unreconstructible posterior canal wall defect. Removal to the canal does not improve access to the sinus tympani. Rarely, our post-operative evaluation may result in the decision to take down the canal wall. Preoperative evaluation. Obvious posterior wall erosion, larger labyrinthine fistula on CT, elderly or infirmed patients in which second look is unadvisable, occasionally with disease in only hearing ear or preoperative conditions that may warrant a canal wall down procedure. Now, advantages of canal wall up or physiological position of tympanic membrane is re-established, enough middle ear space, no mastoid cavity problem. Now canal wall down, it may be a residual cholesteatoma easily found in the follow-up evaluation, Recurrent cholesteatoma is rare. Total exteriorization of facial recess. So these are advantages of canal wall down. One is cholesteatoma is removed fully. Recurrence, there is no recurrence, and exteriorization of facial recess. Disadvantages of canal wall up. Residual or recurrent cholesteatoma may occur. Incomplete exteriorization, second stage operation often required. And disadvantages of canal wall down, mastoid cavity problems often, middle ear shallow and difficult to reconstruct, position of pinna may alter second stage, sometimes required. Meatoplasty, we have, you can see meatoplasty, we give an incision and take a piece of cartilage from the pinna and we suture the flap. Local anesthetic infiltration, removal of cartilage suturing. Technique of meatoplasty, corners meatoplasty, fish meatoplasty, stack meatoplasty similar to corner but inferiorly based. Portman's technique, this flap is lateral, superior and inferior. Complications of mastoidectomy, early complication, facial nerve injury, sensorineural hearing loss, disequilibrium, cauda tympani nerve injury, injury to dura, vascular injury, sigmoid sinus, jugular bulb, carotid anterior, wound infection and perichondritis. Late complication, recurrent cholesteatoma, graft failure, persistent otorrhea, external auditory canal stenosis. Trauma to dura, horizontal semicircular canal fistula. These are complications. Trauma to facial nerve, sigmoid sinus and jugular bulb injury. Trauma to dura, how we deal with the trauma with dura. A dura tear or significant abrasion with herniation of arachnoid tissue with or without a CSF leak require repair. Best repair with a layered closure using soft tissues such as fascial perichondrium combined with a more rigid support material such as bone or cartilage. Broad spectrum antibiotics may be given. Firmly packing the mastoid epitympanum with gel foam with or without fibrin glue can be used to support the repair. Horizontal semicircular canal fistula should always be considered when performing chronic ear surgery. A flattened horizontal semicircular canal sometimes suggests labyrinthine erosion. In such cases, the cholesteatoma sac is opened, the disequamated epithelium is removed, and the matrix is left intact over the canal. If an actual erosion into the fluid space of the horizontal semicircular canal is encountered or suspected during palpation, the cholesteatoma matrix should be left in place. When all disease is removed, several options are possible. Remove all matrix and cover the defect with soft tissue or bone wax. Perform a canal wall down procedure and allow matrix to remain in place as part of mastoid surgery. Perform an intact canal wall procedure and leave the matrix in place to be removed at a second stage when the ear is sterile. Broad spectrum antibiotics and steroids should be considered if the canal has been entered. Iatrogenic injury to a horizontal semicircular canal requires immediate closure by bone wax or soft tissue. Now, if we cause trauma to the fascial nerve, identifying the nerve rather than avoiding the nerve of fascial nerve is fundamental for mastoidectomy procedure. Due to disease, horizontal portion or second genu may be sometimes traumatized. Due to surgery, vertical segment is most commonly damaged. Now, management is we have intraoperative reconstruction of fascial nerve, Post-operative reconstruction of facial nerve early. Post-operative reconstruction of facial nerve delayed more than 6 post-operative days, 6 hours post-operatively. Now, if we have intraoperative, we have minimal injury, partial transaction, and complete transaction. Now, minimal injury, we decompress the fallopian canal proximal and distal to the site. Reserve remaining in the partial transaction, reserve remaining fasciculus, and anastomosis of the separated fasciculus, decompression of fallopian canal proximal and distal to site. In complete transaction, attempt primary anastomosis without tension, capable cable graft if necessary. In post-operative recognition of facial weakness early post-operative, we have immediate post-operative reassess after 4 hours to allow for the injected anesthesia to wear off. Mild paresis, observe steroids surgery if progresses rapidly to severe paresis or paralysis. Severe paresis or paralysis, return to operating room for exploration and repair. Post-operative recognition of facial weakness delayed more than 6 hours or 8 hours post-operative. We have mild paresis and severe paresis. In mild paresis, observe, give steroids and antivirals if 2 to 10 days post-operative. We have severe paresis or paralysis. Observe, give steroids, antivirals 2 to 10 days post-operative, surgery readily indicated. Progress to complete and recovery and absence of 90% of the ENOG to normal size. Normal. Sigmoid sinus, jugular bulb and carotid artery injury. Sigmoid sinus and jugular bulb are characterized by variable anatomy. This fact places these structures at risk of inadvertent injury. Injury to these low pressure but high volume venous structures is initially treated with digital pressure. For small tear, bone wax; for large tear, cellulose type surgical packing. Sigmoid sinus minor injury, adrenaline soaked cotton, laceration, extra or intraluminal packing, severe hemorrhage, sinus obliteration or hemocalypse. Jugular bulb, small opening, bone wax, severe jugular vein ligation, carotid artery injury, small laceration or repair, larger laceration, balloon occlusion, resecting and grafting. Thank you very much. Please like and subscribe and push the bell button, and please promote my channel by sharing. Thanks a lot.